So why we started doing dual attending approach was about 10 years ago. And the first case was in 2007 with really complex spinal tumor. And we realized that, the surgery went much easier, much quicker. The risk of that surgery is obviously very high, and we realized that, the risk could potentially be minimized by performing the surgery as a dual attending.
The two-surgeon approach really starts before we get to the operating room. We identify the cases which are complex revision cases, and we discuss a plan for the patient, and that plan changes based on not only what the orthopedic and neurosurgeon says, but also what the neurologist, the radiologist, and the pain management folks and the anesthesiologist who all come to those conferences tell us.
What type of case might we target is both got to do with the complexity of the case technically as well as with the patient. Oftentimes a patient who may have significant comorbidities, heart disease, lung disease. Specifically, I'm thinking of a woman we did recently who had a history of a stroke, hypertension, pulmonary complications, and she was one who we really needed to think about doing less and think about limiting our blood loss. And by working together, I think we worked efficiently. We were able to do a big operation safely and get somebody who truly wasn't very well fit for surgery but needed an operation through a difficult process.
The cases took about half the time. The outcomes we knew were better. Patients were off the operating table quicker with less blood loss. We felt like the complication rates were lower. It was less work and less stress for us and less physiologic stress on the patient. So we knew we were onto something, and the program really took off after that. The patients love it. They love the idea of having a co-pilot for the operations. Rather than having one surgeon covering 2 rooms, we have 2 surgeons covering 1 room. Patients get the full attention of 2 surgeons for the entire procedure. This is quite similar to when you would take an international flight. You have more than 1 pilot, or when you climb a mountain, you have a climbing buddy. The safety of those activities is really improved by having a partner.
I think Chris became an orthopedic surgeon. I become a kind of partially neurosurgeon throughout those years. It really helped our own self-growth in terms of how we perceive and how we understand the surgeries and how we perform the surgeries.
I think, some of my surgical technique has certainly evolved since I started working with SIG, and it has been really helpful to my practice in patients who I end up doing single surgeon surgery.
It definitely is a mutual learning process. This is part of medicine, is continuing education. And what I've learned in working directly with Praveen exceeds by far anything I learned in my previous training through residency, through fellowship.
We're able to expand the patients and the age groups, patients with other medical issues on whom we can perform these procedures. It used to be when patients were 65, 75, even up to into 80s. Surgeons would never dream of performing potentially a functionally restorative procedure on these patients because they had such high risk. And we can bring that risk down to the point where the surgery becomes reasonable to consider by using the 2 surgeons. That's where I think potentially is maybe even the greatest impact.